Mr. Flanagan, Mr. Gorgian. The people are represented by counsel, Ms. Brazil, Mr. Walgren. Dr. White, once again, is on the witness stand. All the jurors and the alternates are present as well. To everybody, good morning. So, ladies and gentlemen, jury, good morning, ladies and gentlemen. Again, thank you for your promptness. And Dr. White, good morning, sir. Do you acknowledge you're still under oath and still sworn to tell the truth?
Yes, I do.
Thank you. This will be resumption of redirect examination by the defense, Mr. Flanagan. Good morning.
Good morning, Your Honor. Dr. White, when we left off yesterday, we were talking about some of these models prepared by Ms. Ornelas, Dr. Schaefer. There's a lot of variability in these models, isn't there?
Yes, I think we illustrated that earlier with respect to both pharmacokinetic models and pharmacodynamic modeling.
And we were going through some of the variables that you have studied from a clinical standpoint. These studies have also included variability from a pharmacokinetic standpoint, too. Is that correct?
Correct.
And you were asked yesterday about the figure that was used this is a defendant's exhibit, quadruple N, as in Nancy. And there's nothing about this that makes it an exact science, is there?
No, because it's dependent on the individual patient and also the variability in the various parameters that go into the equations. Small changes in the absorption half-life, which I mentioned earlier, and we assumed, for example, 22 minutes. But again, depending on the amount of lorazepam that's given in the stomach, that half-time can vary from 22 minutes up to 40 minutes in the same investigational study.
Well, this model here assumes a 0.0013 milligram of oral lorazepam in the stomach at noon. Is that correct?
Correct.
And that represents 20% of what was actually found by the coroners at autopsy. Is that correct?
Yeah, it represents a lower concentration of free lorazepam in the stomach.
And that 20% representation is meant to allocate 20% of what the stomach contents were to the oral versus the possibility of the other 80% being spillage, referred to by Dr. Schaefer?
Yeah, I think Dr. Schaefer talked about slosh coming back from the distal duodenum into the stomach in a post-mortem situation.
And this diagram also assumes a starting point of 0.05. What does that represent?
Well, that represents the assumption that Mr. Jackson had received lorazepam, which we know he had available. He had multiple bottles of lorazepam. And also the possibility Conrad Murray had given him IV lorazepam the morning prior to his death.
And that possibility is revealed by a statement to the police regarding the night before having been able to produce sleep in Michael Jackson by the use of only lorazepam and midazolam.
Correct.
And we also discussed the other scenario where I'm referring to defendant's exhibit quadruple N, which is quadruple Mary. And up here we have a 0.016 milligrams in the stomach. And we also have a starting time down here where we're starting at 0. Is that correct?
Right. That's an assumption that no lorazepam residual was present in the body. That is, there was no blood level of lorazepam prior to the time Dr. Murray gave the first bolus dose of lorazepam on the 25th. But I would point out that when you look, for example, at the 7 o'clock time at which it was suggested he might have taken some lorazepam pills, if one merely assumes it's, for example, maybe 15 minutes later, then what you see that there would be more residual free lorazepam in the stomach. So you can work these models backwards to essentially get virtually any number you desire. But I'm just suggesting that all you have to do is move that time point a little later It means there would be a little more residual of the pill, dissolved pill in the stomach, and you would also achieve a slightly higher concentration, theoretical concentration, at 12 noon. It would more closely approach the precise value that was measured, which is 0.169, which is 3% more, approximately 3% more than shown in this illustration. But I would just want to make sure you understand that these are just really estimates, and that by moving or shifting things along the time axis, even very minor shifts, you can alter not only the timing of the peak level, but the achieve the blood level that would have been obtained at autopsy, and the amount of residual free drug that would have been found in the stomach at the time of autopsy.
Now, this illustration is not only is the oral illustrated here, but Dr. Schaefer's illustration of the IV. The IV. His illustration is of a theory that would comport with the possibility that 40 milligrams of the lorazepam were used in this bolusing, 10 boluses of 4 milligrams, and your theory here is indicative of oral lorazepam being given at 7 o'clock. It's just an explanation of possibilities.
Yes, approximately 7 o'clock.
Approximately how many possibilities would be subject to being diagrammed if you made variations in the parameters?
I wouldn't say infinite, but a huge number.
And when we put up, I'm going to put up LLL. It does not have Dr. Schaefer's simulation on it, but I wanted to ask you, this starting time at 7 o'clock, if that is moved to 8 o'clock, what does it do to the stomach contents?
It would result in about I believe it's a 0.008 milligram of free lorazepam in the stomach, and very close to exactly what was found at autopsy.
And would it also change the blood level? That
it would approach almost identical to the value found in the autopsy specimen from the femoral vein. But again, I would point out that these models all are subject to variability because we're assuming population parameters for generating these models.
And if we were to go to KK, quadruple K, with similar to what we've just reviewed without Dr. Schaefer's theories or potential scenario?
Yeah, again, you could still give...
We're going back to the base here of 0.
Correct. So you're assuming there's no measurable lorazepam in the body, which is probably not highly likely. I'd say it's highly unlikely it was 0. But if in fact it was, then you can still administer, self-administer 10 of the pills at just before 8 o'clock and get the measured levels of residual lorazepam in the stomach and achieve the concentration that was obtained in the femoral blood at autopsy. You could also break that dose down into multiple doses. You could do very complex analysis where he took a few pills, say at 4 o'clock, he took a few more pills at 6 o'clock, and finally a few more pills at 8 o'clock. So in other words, they were given at different times. And by modeling it, you can generate the same type of numbers that were observed at autopsy.
And so we can move the baseline back down to 0, increase the pills to 10, we can vary the time, and there's a number of scenarios that will lead to a point 169 or depending on the number of pills and the time they're taken, correct?
Correct.
We don't know exactly how many pills were taken, do we?
No one can be sure.
We don't know exactly how much lorazepam could have been used via IV over a period of time, do we?
No, because we don't know how many oral pills Mr. Jackson normally consumed.
And in actuality, it's hard to tell. You can't tell in the human body when you measure blood samples whether or not it's the lorazepam was orally ingested or whether it was injected IV. Can you?
No, as we said, as I pointed out earlier, lorazepam is one of those compounds that's very effectively absorbed from the GI tract, the stomach and the upper GI tract. So virtually anything that's put into the stomach gets absorbed into the systemic circulation of the body. It's anywhere from 93 to 95% of an administered dose. So it's what we say has a high bioavailability when given orally.
Now, moving on to the other subject, you were asked about the point 0.3 figure used from Simon's article when calculating the urine concentration. You recall that?
Yes, I do.
Now, in respect, calculations were done by involving Dr. Schaefer's. The top figure is the simulation prepared by Dr. Schaefer, or it's not. This is prepared by Ms. Ornelas, but this is the simulation starting in infusion at 9 o'clock and lasting till 12 o'clock, at which time the blood level. Green is meant to depict the blood level, correct?
Yes, though I'm challenged with colors. It's a dark line.
It's tough to see at this angle. What exhibit, please?
That is exhibit quadruple U.
If you, Dr. White, do you feel more comfortable in having the hard copy brought up?
No, I'm actually familiar with this, Your Honor.
Okay.
It's Dr. Schaefer's simulation.
Now, the determination of the urine content that would correspond with that. The figure of 0.3 was used, and that is from the Simon's article?
Well, Dr. Ornelas looked at a number of articles, and
The objection sustained. The answer stricken.
This diagram here, as stated where it says based on Simon's, this was taken from the Simon's article, is the parameters there, wasn't it?
well, I believe, as the district attorney pointed out yesterday, the Simon article says less than. I'm not sure if it's less than or equal, I don't recall, but it's said less than 0.03%. So it could have been 0.25, it could be.
Stop right there. You said it could be less than 0.3. This reflects 3% in the simulation, correct?
It reflects 0.3%.
If it's less than 3, say it's 2.5.
No, you're dealing with different decimals here. I think it's important to clarify that.
All right. Thank you. I misspoke, Your Honor. It's less than if it was less than 0.3, if it was 0.25, what would that do to this line? Would it just make it come slightly lower?
It would be lower,
Objection of the honors area of expertise as he testified to yesterday.
How overrule the objection? You may answer.
well, it's, if you assume that's a certain percentage lower than 0.3, you would expect to see a lower level measured in the urine over time. It wouldn't certainly be close to the level, however, measured in the urine at autopsy.
The shadow that is illustrated by the dotted line that goes above and it goes below, that shadow is meant to take into consideration a 50% variability. Is that correct?
It's taken into account a certain degree of uncertainty.
And the uncertainty would be approximately 50%?
Yeah, I think that's not an unreasonable assumption, but it is an assumption on the part of Dr. Ornelas.
And in the event that we had 50% less than the 0.3. That still keeps us in the shadow range, doesn't it?
Yeah, it would be on the simulation about 1 milligram, which is at least 10 times higher than, or approximately 10 times higher than what was measured.
And the measured amount is this line that goes right across the bottom.
Yes, sir.
So whether it's 0.3, 0.2, 0.25, you still have a much higher urine concentration than what was found at time of autopsy. If the scenario was a 3-hour infusion started by Dr. Schaefer, or as indicated a possibility by Dr. Schaefer.
Yes.
And also, is there anything else that's inconsistent with this model by Dr. Schaefer with respect to, was there lidocaine used?
Well, in recalling Dr. Schaefer's report, it was a little confusing, but my reading of the report, I think you have a copy of it, but suggested that propofol and lidocaine can be mixed together. I have to say, as a clinician, I've never mixed lidocaine with propofol for an infusion, because we typically give lidocaine, which is a local anesthetic. Mr. Jackson referred to it as anti-burn, I believe. But you administer that either with propofol or by itself into the intravenous just before you start propofol, because propofol, one of its most common side effects is intense burning. And this burning is influenced by many factors: the concentration, the speed of injection, and most importantly, the size of the vein. And when you're putting IV cannulas into very small veins, as was the case for Mr. Jackson because he had no larger veins, the burning is intense. So you have to assume with this model that lidocaine would have been given just prior to 9 o'clock. And I think Dr. Schaefer gave 2 scenarios. One where he added 10 cc's to the 100 ml vial that you saw. But again, that's a glass vial, and I don't think physically it's possible to inject 10 cc's of lidocaine into that vial to mix it up, because you would have 110 mLs in this glass vial, and if you look at it, it's pretty much full with just the propofol. So I think what he then assumed was that Dr. Murray had drawn up a 1-to-1 mixture of lidocaine and propofol. And I think that Dr. Schaefer said in his report that was consistent with the levels. That is 50 milligrams of propofol, 5 cc's, drawn up with 5 cc's or 50 milligrams of lidocaine to fill up that 10 cc syringe that I showed you. If you gave 50 even if you gave 25 milligrams or even 50 milligrams, that is, if you gave the whole syringe prior to starting this infusion, my estimate, based on the known short half-life, that is the time at which it takes for the lidocaine level to fall in the blood after a bolus injection, there would be virtually no lidocaine, 0.84 micrograms per milliliter lidocaine.
So in the event, in this scenario, you gave any lidocaine whatsoever, it would be at the beginning of the infusion.
That's the only reason we would give lidocaine. I can't conceive of a reason for just giving a bolus of lidocaine during an infusion when a patient's sleeping.
You would not give lidocaine once the infusion has started and the patient is sedated. Is that correct?
That's correct, unless the patient was, for some bizarre reason or some unusual reason, complaining of a lot of pain at the injection site, which would actually suggest that the IV may be, call it, infiltrated or not flowing properly.
Or if perhaps if the patient woke up and you had to, would you give lidocaine to to increase the infusion?
Possibly, not typically. When we're doing sedation with these type of infusions, which is what I described as modern anesthesia care, we typically If we need to give a little bolus of propofol to get them to a little deeper sedation, we don't commonly give additional lidocaine at that point, because normally if they're having pain, it's just when you start with the first injection for anesthesia or for sedation. And once you're beyond that period of time, usually the pain in the IV site is not a problem.
So what you're saying is in this model here, or this scenario, the lidocaine would be given at about 9 o'clock, and whether it's 2.5 cc's or whether it's 5 cc's, you'd expect it to be gone out of the system at 12.
I would, yes.
And so that wouldn't account for the 0.84 that was discovered at autopsy.
Correct.
On the scenario that involves the two uses of propofol, the 25 milligram slow push over 3 to 5 minutes shown here, that would have been accompanied by lidocaine. Is that correct?
Yes, there would have been a transient increase in the lidocaine level. Given its half-life, the curve would probably look somewhat similar to the curve that Dr. Schaefer produced for us and is illustrated on this graph, on the upper part of the graph.
And lidocaine would have been given also at the 1040, 1050, whenever this dose, the rapid bolus dose was given also. Is that correct?
Yeah, the lidocaine curve would then, of course, not be so smooth, or the little peak there would be more peaked. It would be similar in shape to the propofol curve, perhaps a little lower, and because the concentrations are a little different.
And as we have toxicology results at time of autopsy, 0.84 lidocaine, would that correspond with the amount of lidocaine you'd expect to still remain once this bolus injection was given?
I believe it's fairly close to what was found at the time of autopsy in the femoral blood, yes.
And this urine scenario that goes along the bottom here, if this is also based upon Simon's 0.3% measurement?
Yes, it is.
If you knocked it down to 2.5, would you get something that's very close?
Well, you'd get a lower number, but again, as I pointed out, this scale for the unchanged propofol is a very expanded scale. So it would be lower, unquestionably. It would probably drop down the second curve after the second bolus to a level that's at or slightly below the dashed line. Again, I just want to emphasize that the dashed line is a measured, quantifiable concentration of free propofol in the urine. And the other lines, the models are simulations, and again, subject to all the variability that I've tried to explain over the last 4 days. And, they only give you a visual of what could have occurred, but again, I would caution not to attach yourself to the specific values. The fact that they're not zero, though, is important, that they're actually measurable drug present.
And once again, this line takes into consideration by the dashed line above and below the solid red line, takes into consideration a plus or minus 50% variation.
Yes, 50% degree of uncertainty.
And
yes.
that uncertainty can take the 0.3 all the way down to a 0.15, couldn't it?
Yes, it could.
On another subject, we've spent a lot of time talking about standard of care. Is there a difference between standard of care and standard of actual practice?
Yes. I mean, standard of care is the ideal. It's what we would seek for every patient. But there are many circumstances, and I indicated a few, where it's not necessarily possible or it's not common to actually have the highest possible level with respect to guidelines that are generated by distinguished organizations. Committees come up with these guidelines. Some are not based on evidence. Some clearly are important for patient care. But I could give you examples if you want.
Well, give me an example.
Of where the standard of care may not be the standard of practice. We talked yesterday about a whole list of monitoring approaches that would ideally be used every time a patient receives a sedative infusion or multiple doses of a potent intravenous drug for sedation or anesthesia, and that would be capnography. Capnography is used to measure end-tidal CO2, which is what we exhale. And as I mentioned, when we have a tracheal tube in during anesthesia, we can very precisely measure the CO2 in the lungs. But when you're using a catheter device to measure CO2 at the nose or in the mouth, there's gas coming in, room air diluting it, and it's not always reliable. Also, if the patient snores or is a mouth breather and you have the cannula in the nose, you won't detect appropriate CO2 values because you have to be moving air. So although I think it is a useful monitor, I mean, when we developed the sedation techniques back in the early 80s when I was at Stanford, we used to put a cannula through nasal prongs. We'd actually put a little IV cannula just so we could hook it up to our capnograph machine. Capnograph is the device that's used to measure CO2, carbon dioxide. Sorry, I didn't say that. So it's something that we'd like to have, but it's in many situations where propofol is given in plastic surgeons' offices, in GI clinics, in other venues apart from an operating room, it's simply not used.
And
another example would be, for example, an infusion. Okay.
The objection is sustained.
Sorry.
Everything starting with, and another example is stricken. Disregard that. Thank you. Mr. Flanagan?
when we ended the other day talking about the 100 milliliter infusion talked about on this diagram prepared by Dr. Schaefer, you indicated that it was not reasonable because it didn't correspond with Dr. Murray's statement, it didn't match up with the urine test expectations at time of autopsy, and there was no physical evidence at the scene that would support this. Do you now also include the fact that lidocaine would have been used at the beginning of the infusion and would result in a near zero lidocaine level at noon?
That is my opinion, yes.
What exhibit?
Exhibit quadruple S. Talked a little bit yesterday about minimal sedation, moderate sedation, and the standards of the ASA House of Delegates put down on October 27, 2004. Now, this minimal is...
Could you expand a little bit? It's tough to see.
Okay.
Thank you.
Where it says minimal sedation anxiolysis. What is anxiolysis?
Well, as I stated yesterday, anxiolysis is reduction or prevention of anxiety.
Now,
or nervousness.
how do you relieve anxiety?
You give anxiolytic drugs that have the potential to reduce anxiety. For example, benzodiazepines, propofol, and various commonly used sleep medications, because often inability to sleep is related to patients being anxious.
Well, give us a sleep medicine maybe everybody here can relate to. What would you think of maybe an Ambien?
Okay, I'm familiar with it. I don't use it or have any experience with it, but...
Would Ambien cause a reduction in anxiolysis?
Well, it would possibly cause, in anxious patients, a reduction in their level of anxiety, yes.
Now, when you use a drug to reduce the anxiolysis, for purposes of producing sleep. There's different degrees of sedation, isn't there?
Yes, as we discussed, the degree of sedation would depend on the dose, various individual factors. Patients that would take an Ambien or multiple Ambiens every night would have less of a response than someone like me who's never been exposed to it. Would take one Ambien, I might sleep for 12 hours. I don't know.
Now, say a person did take an Ambien or lorazepam or some midazolam. Is there a concept that describes the sedation as subject to verbal stimulus?
Well, if you look on this ASA chart, which I would also point out, it was approved initially in 2004, but it was actually amended in 2009, so it's fairly recent. Yes, minimal sedation, which also includes anxiolysis, so this is the one end of the continuum that we've been talking about throughout this trial. Responsiveness is normal response to verbal stimulation, so that a patient could be resting quietly in a sleep state, but they would respond to verbal stimulation.
So if I took an Ambien to go to sleep and I actually fell asleep on the Ambien, you would expect to be able to come into the room and call my name and I'd wake up?
Under normal circumstances, unless you took a massive amount or you were extremely sensitive, then it may take me shaking you a little bit or calling your name very loudly.
Okay. In the event that you gave a slow bolus of propofol, say 25 milligrams over 3 to 5 minutes, would you also expect to be able to wake up the patient by verbal stimulation?
Certainly, giving that dose over 3 to 5 minutes, I would expect a patient to be in a very light state of sleep, if they're even sleepy at all. The studies that our group and others have done have found that in these very low doses, you can demonstrate reduction in anxiety scores, but they don't produce amnesia or lack of recall and generally do not produce sleep. It could, in a patient who's very tired, though, produce a light, restful state.
We've had doctors testify in this case that the slow injection of 25 milligrams over 3 to 5 minutes. I think it was Rochelle Cooper, Dr. Rochelle Cooper from UCLA, indicate she's not sure that a person would go to sleep on a 3 to 5 minute injection of 25 milligrams of propofol. Would you agree with that?
Yes, I would.
And it's also not certain that you give a person an Ambien, they're going to go to sleep either. Is that correct?
I believe that's correct, although I don't have a lot of experience administering Ambien.
But in the event that the person does go to sleep under either of those scenarios, you would expect to be able to rouse them verbally.
Yes.
And noise in the room would probably cause them to, you would expect, could potentially cause them to awaken also. Is that correct?
Correct.
So we're really talking about minimal sedation here, aren't we?
It's, my understanding based on the doses and medications that Dr. Murray administered, they would be in the range of minimal sedation.
And in that minimal sedation, the airway you'd expect to be unaffected?
Yes.
Ventilation would be spontaneous?
Yes.
And there should be no effect on the cardiovascular function.
Correct.
And in the event that the propofol were even present after a period of 5-10 minutes, you'd expect even that to be totally gone. Is that correct?
Correct.
Okay, lastly, doctor, we talked about, I want to show you, exhibit It's quadruple R, Your Honor. It shows here the propofol level of 2.6 femoral concentration, meeting the femoral vein concentration of lorazepam at 0.169. Is that still what you feel the most likely cause of death in this case?
Yes, I do. And I'd also point out that there actually is lidocaine present as well at that time, which you would expect to find because the final dose of fatal dose of propofol would have contained a mixture with lidocaine.
And that lidocaine level, is that traced by, you got to take my word for it, but it's a green little squiggly line that goes up, comes down, and then goes up right adjacent here to the propofol line. Is that the one you're talking about?
Yes, sir. I would expect they would follow very similar patterns.
And that lidocaine line that ends up here at 0.84 corresponds with the toxicology at time of autopsy?
Well, I didn't do the modeling myself, so it's just a guess, but I would expect it to be in that range.
Speculation, he says it's a guess.
The objection sustained. I didn't do the modeling myself is the answer. Everything thereafter is stricken. Thank you.
Is this, would this modeling be consistent with your knowledge of lidocaine and the blood concentrations received by respective doses?
It seems reasonable.
Thank you. Your Honor, that's nothing further at this time.
Mr. Flanagan, thank you. Recross-examination, Mr. Walgren?
No, I have no questions. Thank you, Your Honor.
Thank you. May Dr. White step down, subject to recall, Mr. Flanagan?
Yes, Your Honor.
Mr. Walgren?
Yes, Your Honor.
Dr. White, I want to thank you for your testimony. Sir, please don't discuss your testimony of the facts of the case with any other witness until we finish the trial. You may step down. However, you are to remain on call, and you're subject to recall. Thank you. May I see counsel, please? Oh, may I see? After a big 42 minutes, you take a mid-morning break, remembering, of course, all the admonishments, written and verbal. We have some other matters we have to discuss for a little bit. So please enjoy the break, and we'll buzz you out in a few. Thank you.